As we said in our previous video about meniscal tears, you find the link to this video attached below, in some kind of meniscal lesions it's worth to proceed with a surgical treatment. Surgical treatment may be represented by a partial meniscectomy, removing a torn piece of the meniscus, or by meniscal repair with a suture. And it's just about this topic, meniscal suture surgical intervention, that we'll talk about in this video. Good morning everyone, I'm Stefano Teramo and this is Arthroscopic. As yet demonstrated by scientific literature, the auscultation of a section of the meniscus will be implicated in a progressive wasting and degenerative dynamics at cartilage during the following years. So, when possible, we have to try to save the meniscus and to proceed with the meniscal repair by suture. Unfortunately, as we said previously, not always is possible because it depends from some meniscal features, such as the morphology, the shape of the lesion, the localization into the meniscus, the quality of the meniscal tissue, and the age of the patient. Now that we have cleared that not all meniscal tears are fit for a treatment with suture, let's try to identify an ideal meniscal tear to be sutured. In this case, the ideal pattern would be showing a longitudinal tear. It has a longitudinal lesion that doesn't affect the white zone of the meniscal body and extends in a longitudinal way through the red zone. Better if it happens in a meniscus with a good tissue quality and in a patient with a not advanced age. The best should be a young patient with an age not elder than 45 years. The presence of this feature should allow our repair by suture a better prognosis and a higher chance to get a scar healing of the lesion and used to reduce the risk of a failure after a repair. And now, before entering our virtual operative room, let's try to give a quick look to what we do in fact when suturing the meniscus by a little skin here. If we try to image the meniscus as cut by a coronal point of view, it has a superior to inferior cut. We could image a meniscus such as a triangle with this segment as a meniscocapsular union and as this triangle shaped area is the body of the meniscus. We know that meniscal vessels are localized at the meniscocapsular union and then they progressively go through the red zone of the meniscus in progressively reducing density. Try to image the prototypical meniscal lesion to be sutured. It has a longitudinal total tear at the red zone. What we'll do in order to suture that will be to pass with a specific device that we'll see in a few instants, a device that allows us to pass through the both segments of the meniscus, perforating the body of the meniscus and reaching the meniscocapsular union in order to release here a little transversal anchor that will stabilize our suture wire, high resistance wire, in order to give a notch, making a loop at this level, and then to push another device just in this area and to make a notch that will constitute our suture. This will stabilize our meniscal tear and it will allow the lesion to heal in the following weeks by creating a scar tissue at this level. If it happens with no problems, finally we'll have a healed meniscus with a good stability and finally a better prognostic from a clinical and functional point of view. This is our goal. But now let's go to give a direct look with our operative image from our surgical room. First of all, let's start giving a look to our arthroscopic portal. These are small incisions made in the anterior aspect of the knee. As you can see in this image, there is an anterolateral portal, just here, that is made just inferior-lateral to the inferior pole of the patella, just lateral to the lateral edge of the patella tendon. This portal is most commonly used to start our arthroscopic exploration by inserting the camera of our arthroscope and to use it as a visualization portal. On the other aspect of the knee, we have the anterior medial portal that is most commonly used as an operating portal through which we can operate with our surgical instruments, even though we've not to fall in the easy mistake to consider it a stiff way of operating. It's not so because, in fact, we have to have the flexibility to manage both portal and to make an inversion of anteromedial and anterolateral portal, switching the camera and the surgical devices in order to get a better point of view and an improved perspective on the joint. Now let's get inside the arthroscopic view we have during surgery. What we see here is our first insight on the knee joint. We mostly start with the patellofemoral area where we can see above the cartilage surface of the patella and below the femoral trochlear, that is the anterior aspect of the distal femur. As it's possible to appreciate in this image, we may see both an healthy cartilage, as in this case with a good chondral trophies, or a westernate and progressively degenerative cartilage, like in this other case, where we see a degenerative fibrillation of the cartilage surface. Then we'll progressively shift our arthroscope medially and visualize the chondral surface of the medial femoral condyle. At this level, we can explore the medial recess too. In this specific case, we can appreciate a little synovial plica that is a high-density synovial stringed medial compartment. Then we'll finally reach our femorotibial medial compartment that shows us the presence between the femur and the tibia of the meniscal fibrocartilage, the medial meniscus exposed. Now let's see how we suture a little longitudinal posterior medial meniscal tear. If we focus our attention on this video, we can see our arthroscopic probe to look for and to reach the lesion on the posterior horn of the medial meniscus. The terminal part of our probe, of our metallic probe, is inserted through the meniscal discontinuity and lets us appreciate how there is a small longitudinal tear of the posterior horn with a consequent moderate instability of the posterior horn of the meniscus. This is not a great tear, but it's enough to provoke mechanical symptomatology due to this mild instability of the segment. Once we've assessed that our lesion is fit for a suture, we proceed with the first path, that is the scarification. The refreshing by a shaver. There is a small motorized device like this of the marginal segments of our lesion. This is because we have to provide sufficient blood supply to the lesion to try to stimulate the bleeding of the terminal parts of our tear and thus to improve our chances of healing and scarification tissue after repair. Then we proceed indeed with the suture of our tear. In order to reach our goal, we use this device that allows us to make an all-inside repairs, because in this case, due to the position of the lesion, it's not worth and not necessary to proceed with an in-out or out-in suture as in other cases in other areas of the meniscus. This is a prototypical posterior medial lesion that fits good with an all-inside repair using an instrument like that that presents a metallic penetrating terminal part with a peak that's plastic plate that's intended to be positioned on the meniscocapsular unit. What we do, in fact, is to penetrate with this tool through both segments of the meniscus, the central and the peripheric segment, and to deliver our plastic device in the meniscocapsular union in order to anchor the suture, and then by delivering a second peak plate by penetrating the meniscus, we're able to finally tense and give tension to our high resistance wire and to perform this meniscal suture by a high resistance nut. At the end of the procedure, we try to reproduce the subluxation, the instability of the posterior horn of the meniscus that we saw before the suture, but in this case our probe is not able to penetrate the lesion because it's repaired, and we cannot see the same instability we saw before. On the lateral meniscus, the steps we follow in order to make a suture are the same, but we have to consider not only an anatomical different shape of the lateral meniscus if compared with the medial one, but also a different biomechanics. Because indeed, medial and lateral meniscus have different biomechanical behavior because the medial one is much more stable and stiff than the lateral one because there are a lot of connections between the meniscus and the tibia, we call meniscotibial ligaments, in a higher density and stronger than it happens on the lateral side where we have meniscotibial ligaments, but there is not meniscocapsular continuity on a specific region that we call Popliteus hiatus. It has the space in which the popliteus tendon passes through, and it's a really crucial anatomic structure we'll see in another occasion in order to contribute with biomechanicals of the posterolateral corner of the knee. We have to consider that this posterolateral popliteus hiatus is a looser and quite unstable section of the lateral meniscus, and by arthroscopy we can assess this hypermobility of the lateral meniscus, and we have not to fall in the easy mistake to consider it as a lesion and to try to stabilize it by suture. It will be a real mistake because it's normal and biomechanically physiological that the lateral meniscus shows an higher mobility than the medial one. Besides these considerations, technically the steps we follow in a lateral meniscus suture are the same than the medial one. That is, first we assess the features of the lesion. In this case, we see a wider and much bigger tear of the lateral meniscus than the one we saw before. It's a quite unstable portion of the body of the meniscus and it extends from anterior to posterior part. We usually call this pattern of lesion a bucket handle lesion of the meniscus. In this case, we see that it's in transition zone, it's a red-white zone, but due to the very young age of the patient, we decided to give it an opportunity to try to save the meniscus by performing a suture. So, the first step is assessing the lesion by probing the instability of this wide, unstable portion of the lateral meniscus. Once we've scarified the meniscal edges by shovel, we're able to proceed with the stabilization by an all-inside suture, penetrating both segments of the meniscus and delivering the peak plate on the meniscocapsular union. Finally, we tense a rope and we finish the procedure by confirming the stability of the meniscus after repair by probing again. Meniscal suture is a kind of intervention we normally perform in day surgery. It does surgery during the morning session in operative room and then during the afternoon we normally discharge or patient indicating a period of 3 weeks without weight bearing. This is not an universal considered indication because there is not a standard protocol for the post-operative management of this kind of surgery, but we can say that there is a quite widespread consensus over the opportunity to avoid the body charge of the operated inferior limb during the first period. We suggest 3 weeks. Then, starting from 3 weeks post-op, we have a progressively increasing weight bearing by pain tolerance, and finally to lift the crutches and to go home with rehabilitation during the first months. We have to consider the crucial aspect of rehabilitation and physiotherapy, thus the physical manual therapy. In order to gain flexion, we suggest not to force the first 90 degrees of action during the first 3 weeks and then progressively increase the range of motion. This has to be accompanied by a muscle stimulation and muscle strengthening that starts being an isometric exercise and follows in the second session of rehabilitation with both open and closed kinetic chain exercise in order to strengthen muscle and to improve biomechanics and proprioception of the joint. About the very important aspect of the return to play for sportsmen and sportswomen, we have to say that normally in this kind of surgery we have a little slower progression in return to sport activities if we compare it with the partial meniscectomy, as we'll see in our following video. In case of suture, we have to suggest the patient patience in order to reach a good recovery, and we normally recommend a period of 10-12 weeks of delay in returning to sports, above all if we consider impact and pivoting sports such as football and basketball. That's all I'd like to say you about meniscal suture surgical intervention. So I thank you for your attention and your patience, and I give you appointment for the next episode of Orthostrive. Thanks a lot, and bye bye.
Come home with me, loving me too, waiting for long tree. I'm waiting for you. There is no choice. Nobody cries too long for me. Sometimes I fall and rise, you know. Some people fly so far.